So I'm going to talk to you about something new that we've been working on over the last few years, and now it's reaching a sort of clinical application, but I mean, we're still a long way from getting it to any sort of commercial use itself. But I'm going to sort of introduce this as something that we've been doing now as well. So basically, we're going to talk about terahertz imaging, and I'll try to explain this to you and why this is useful to understand corneal biology. So we all know that basically corneal hydration is, or the theory behind corneal hydration is basically from Morris's pioneering work in the early 50s, where you have this sort of leaky leak hypothesis, where you have this leaky barrier, and then you have the endothelial pump to basically pump out the fluids itself. And you can see that with the ionic molecules over here on the right-hand side, sodium potassium ATPase pump, and the chloride, and also the bicarbonate basically being pumped out into the aqueous itself. If you look at 3D imaging of a corneal endothelial cell and you go from the apical side, so this is basically facing the anterior chamber, and you go basically more anteriorly up into the to Descemet's membrane, you'll see the actual morphological shape from this 3D reconstruction diagram over here does basically change. So it fits into this whole concept of where you have this basically leaky barrier itself. And the existence of this swelling pressure in a charged gel is obviously what we call the Donan effect. And that's how basically the corneal functions, an idea basically keeping the corneal basically dehydrated. Now, when you basically look at light transmission as a factor of several kind of variables itself, most of the time you actually think that the increasing thickness of the cornea itself is actually affecting the light transmission. But actually, if you look at the diagram over here, where you get a variation in the wavelength of light, most of the light transmission effects in relation to an increase in the corneal thickness is really at the shorter wavelength of the spectrum itself, so more like blue light as opposed to basically infrared light itself. And actually, you have to have an increase in thickness quite significantly if the cornea maintains clarity. So what that means is that when you get an increased thickness related to water, it has to actually be super thick before the patient's actually going to have any reduction in light transmission. But if the thickness is increased due to, say, a scar, they can have a much more profound reduction. So when you're looking at thickness values, it basically depends on what's the cause basically of the thickness itself. Other variables actually have much more effect on light transmission with respect to its effect, whether it's radius curvatures, of course, we know basically from keratoconus, basically increasing the fibrillar density. So this is basically typically a scar formation as well. Now, we know that the various parts of the cornea have a different effect on hydration, okay? And that's because related to its collagen structure. If you look on the left-hand side over here, when you basically plot the function of basically stromal depth in relation to basically swelling, you can see from this line over here itself, the anterior cornea inherently has less ability to swell than the posterior cornea. We know that because the lamellar arrangement of the collagen structure in the anterior side is much more tightly packed. The posterior side is basically much more basically widely spaced, so the posterior cornea can get basically more edematous. That's why in early Fuchs, you get much more edema in the posterior part of the cornea before you get the anterior part, because the anterior part can basically hold this basically together itself. Now, if you section the cornea 100 microns at a time and you submit it to really high levels of intensity, and then you measure the variables again you see a difference itself. So your burst pressure for hydration again is more in the posterior part of the cornea, as you can see from my cursor on this side over here, compared to basically the anterior side as well. And you can see this in an early time phase and also basically in a chronic condition as well. If you look at the fibrillar spacing structure, you will see that there is this variation in the collagen fibrillar spacing structure, of course, as the cornea becomes more edematous. So if we look at this in a little bit more detail, it's an example of a change in the refractive index with respect to the effect of hydration. And the reason why people start having problems with the visual acuity is because it's a refractive index change of the water in the cornea as opposed to actually the scattering basically of light itself. If you look at this chart over here, this is two eyes, one from a human cornea, one basically from a patient eye with basically Fuchs dystrophy. This is an EM basically showing the difference in the fibrillar arrangements on this side over here. You can see that there's a difference basically in the scatter itself, but it's not, there's not a disparity in the collagen fibrillar arrangement. It's the water in between the collagen lamellae that's causing basically the light scatter, and that's causing a refractive index change, and that's why the patients basically have an issue with the vision itself. So it's the water content in between the collagen lamellae. So what we do as clinicians now when we assess basically corneal hydration, or when you basically see a patient with corneal hydration, is that we do basically two tests. One is what we call basically an anatomical assessment. So you do specular microscopy, where this is done basically looking at cell count, either specular or in vivo confocal microscopy, and it's telling you that the cells are there or the cells are basically not there, okay? So it's like basically telling you that something is basically there. Or you do basically AIOS2025. But what AIOS2025 is telling you is basically just telling you how thick the cornea is. So it's giving you a physiological function of those endothelial cells. It's not telling you the hydration level, right? It's just telling you how well those endothelial cells are basically pumping from the eye. You can do it with AIOS2025 or basically with shine fluid imaging. And you can see this in an example over here where you see basically corneal thickness, not massively swollen, about basically 540, but you can see there's some subclinical edema on the basically posterior part of the cornea. So clearly, and I'll show you some more examples in a minute, clearly this cornea has subclinical edema, but your pachymetry value is basically within the normal range. It's basically around about 570, 580. Right? So you're not measuring hydration. Another way of looking at this is basically this example over here. You have two objects, right? One is basically a brick and one is a sponge, okay? The objects themselves have the same volume. So if I measure this on OCT, the volume is basically the same itself. So if we measure the thickness like you do with pachymetry, it's the same basically on the both sides. There's only two objects here, so if you do anatomical measurements, say with specular microscopy, for example, there's basically only one. But everybody in this room knows that the density is different between that brick and that sponge, right? So when you're looking at a cornea, you're not measuring hydration. You're basically measuring the volume to basically understand the thickness, and you're measuring the number of cells to tell you the number of cells there. You're not basically measuring hydration. Okay, here's another example. Patient of mine, right eye, left eye, another patient and stuff. The corneal thickness on the right side is basically 610 on pachymetry. Left eye is also 610. Is the hydration level the same? The answer is no. Look at the subclinical, look at the posterior flow on the right-hand side over here. It's positive. On the left-hand side, it's negative. Okay, so clearly this one on the left-hand side over here has got subclinical edema. Okay, so the hydration is higher. On the right-hand side, on this side over here, the patient has not got subclinical edema. It just happens to be a thick cornea. In fact, the right one is from a patient of mine who came for refractive surgery, and the left one's basically from my corneal clinic. But it's just to show you that what we're measuring is not basically the same thing. Another example over here, this is a lady, patient, daughter, actually another patient of mine that I did DMEC on. She had refractive surgery when she was 20. She got early onset Fuchs, okay? So if you look at her corneas over here, obviously you can tell she's got Fuchs from the specular microscopy and the color photograph imaging on the left-hand side. But her corneal thickness is going to be 429 on this side itself. How are we going to know that her basically cornea is going to become decompensated from the Fuchs? There's no point doing pachymetry or basically shine fluid imaging, right? Because of course it's always going to basically be in the lower end of normal because she's had previous refractive surgery, right? So what she wants to tell me is that, is my cornea getting more hydrated? Am I going to have a problem with my Fuchs over the time period itself? How are we going to basically measure that? So the way we do this is basically using terahertz imaging. And terahertz imaging basically functions at a level over here on the infrared part of the spectrum. We use a femtosecond laser to generate the terahertz image itself, and it's highly sensitive to water content itself. It's a non-ionizing radiation, and it's biologically basically innocuous itself. You have a whole frequency of different wavelengths or frequency of wavelengths of terahertz imaging itself, and it's short enough to basically give you reasonable resolution, but it doesn't obviously penetrate very deeply itself. So for the cornea, it's actually a perfect thing to use because we don't basically need deeper penetration, because if you have long penetration, you're going to get a lot of light basically scattering itself. So where do we think we can apply this to? Well, of course, basically, as I said in the introduction, you can apply this for corneal, basically, hydration levels. So look at basically evaluate the density of hydration, because you can basically monitor water progression. So you can use this for basically imaging for progression. You can evaluate treatment options also for the ocular surface and for the cornea itself. But you can also basically use this to get other measurements on the cornea itself, such as hysteresis and basically corneal scarring itself. So there are actually many basically uses for this thing itself. And this paper over here of ours, you can basically show all the possible uses that we think we can actually use this device for once we get this basically all the testing for this done. So we've been working in this area probably for about maybe the last sort of 8 years, and there's a whole series of publications that I can't really obviously have time to go through, but you can get them online, and some of these are free downloads as well, to look at how we investigate the safety in animal models to really look at basically how this imaging system basically works. So the imaging beam profile works on a frequency range. So we basically take a whole different frequency of terahertz imaging, and you have an incident beam that's generated by a femtosecond laser, and then basically a light source on the other side where you'll basically capture the imaging. And depending on the focal plane of where you scan all the way from the ocular surface all the way down through the stroma itself, you will then basically get a different wave kind of pattern as you basically go deeper into the corneal surface itself. So initially our studies were basically done on human eyes to look at differences relating to hydration pattern, and of course we did use corneal thickness. We did use corneal thickness as a biomarker to basically assess how the hydration was getting worse and stuff, and how we were basically picking up the signaling as from there as well. We repeated experiments, basically once we did in vitro studies, basically in vivo, so these were basically done in rabbit eyes to understand the effect of basic hydration. We induced basically bullous keratopathy in the rabbit, and then we basically scanned the rabbits serially basically over time to measure the hydration effect as the basically cornea's got more hydration in relation to basically the terahertz signaling you can see on the left-hand side itself. And once we were getting some data from the signal itself that we were able to correlate to basically corneal thickness, we then basically proceeded to basically see how safe this signal was. Safety tests were basically done in rabbits, where what you essentially do, you put a rabbit there and you basically have the terahertz imaging firing at the rabbit eye for almost 24 hours, basically non-stop, and you basically then look at the rabbit basically at a cellular level, and we're able to show no effects on any part of the eye, lens, retina as well, and even on the electrophysiology of the retina itself to show that it's completely safe to basically use. And of course, it comes from the same generated pulse as femtosecond lasers, which are commonly used for refractive surgery and also basically for cataract surgery, so we knew that it was going to basically be safe itself. So with all this data, we applied for basically an HSA license in Singapore to be able to do a first-in-man trial. This is a prototype machine that we basically have. It's attached to basically a slit lamp, and of course there's a massive computer basically linked to do this itself. And the idea was to basically do a phase 1, phase 2 study. Phase 1 study done on non-seeing eyes, and then we basically proceeded this to basically a phase 2A study where we took patients from my corneal clinic who basically had Fuchs or basically mild edema, likewise basically patients who had scars as well. We have two machines or two basic different kind of softwares available. One is basically giving you a single spot, basically reading itself, which is then correlated to hydration. And the second is basically imaging the entire cornea and then giving you a map similar to what you will see from basically when you look at a standard basically tomography map. So we've completed the basically phase 1 study. This was basically 6 eyes, completed normal follow-up, basically normal, basically seeing eyes. This is the setup that you have. So you can see over here, this is the camera. It works very similar to like a slit lamp to basically get the imaging. You've got to focus the light beam on the cornea itself, the wave pattern that you basically get assigned at the moment. And then from this basically wave pattern beam, you can then basically measure the hydration content. So the machine will then give you a hydration content value. And this is basically compared against in vitro standard controls to again give you a valuation basically of hydration as well. The safety profile from the phase 1 data was very good in our patient basically profile. There was no change in the uncorrected distal acuity or even corrected visual acuity, and no impacts on the corneal lens and the retina, similar to what we basically saw in the animal studies. And likewise at a cellular level, we had no basically changes in the cornea as well. The phase 2A of the study, the target recruitment is 150 patients. So currently we're on about 80 patients at the moment now as well. And you can see from this chart, from the PCA plot on this side over here, a nice separation between patients from normal controls compared to those that basically have edematous basically corneas or higher levels of hydration corneas itself now. And what we're now trying to do is basically upgrade the software in collaboration with the engineering university in Singapore to basically be able to convert this basically to a map profile as well. This is what we currently basically have, so it's a much larger machine over here itself with the newer kind of software. The patient basically puts their head on this side over here, and then from the terahertz basically scan, you get a map that looks like this over here on the surface, and this will actually give you a real-time scan of the whole hydration on the surface, and depending on the focus itself, you can get your tears, so you can basically have somebody, you want to study the tear film, you can look at the ocular surface, into the stroma, and then basically the posterior part of the stroma itself. So this is where we currently are in the device basically development. So we're up to basically phase 2 trial. So this is going to basically go through to 2026. And subsequently to this, we're then looking at other applications. So applying this either as a standalone instrumentation and then or maybe linking it to a laser system as well. So terahertz basically imaging. So basically, I think it's a sort of new modality that we can see in our armamentarium to measure basically hydration coefficients in the cornea. It's quite an exciting technology. I think it can be used for many things in basically clinical practice, and hopefully in the next few years we will have a commercial device available that everybody can have access to as well. Thank you for your attention. Okay, any questions on?
CAM has densitometry.
Yeah.
The 9 millimeter of the cornea is measured. How different that
Not,
is?
densitometry is scatter. This is hydration. Densitometry is measuring scatter. So it's quite good for monitoring scars. So I use densitometry to monitor scar, to move scar formation, but it doesn't, and it's measuring scatter of light. This is measuring hydration.
Hydration.
This is hydration. So like I showed with that example, the Fuchs case itself, if you basically put densitometry on that, actually you would get no difference in the reading. But I have examples of Fuchs cases that have actually densitometry scarring itself. But that's giving you a scar because you're giving a measurement of scatter itself. This is actually telling you basically what is the hydration content. We know normal cornea is 78% basically water content itself, but it's actually telling you what the hydration level is, irrespective of your pachymetry thickness. Because pachymetry is we all use pachymetry, but it's not telling you, pachymetry is not hydration, right? Anyone who does corneal refractive surgery, everyone knows, you see in our refractive surgery patients, we beg for our patients to be 610 microns, and in our corneal clinics, we have many patients that are over 600 microns, but in the refractive surgery, they can be completely normal itself, but we have no measure of measuring water itself, and that's why we're looking at water signal here, not scarring.
We can also measure the aqueous density?
Yeah, so one of the limitations. So we haven't looked at that, but one of the limitations is the focusing ability for the terahertz scan. So because it's short wavelength, right? So it's basically ultrasound. So it's short wavelength itself. It's infrared. So it's infrared. You cannot have the deeper you go inside the eye, the more scatter of the signal it has. But it's possible. But we haven't looked at that, mainly, to be frank, because of the fact that we wanted to get something up and running with on the corneal side first of all, and then once we get an application from there. But you're right, it's actually possible to do that because we could focus slightly deeper inside the eye. Aqueous will be doable. Lens, I'm not sure, but aqueous certainly should be doable. Yeah.
Thank you.
Good. Yeah. Absolutely. So you can segregate. So it's just changing the focus plane. So it's like when you do, for example, when you do confocal or imaging, for example, you adjust the plane of focus itself, and then anterior, posterior, and of the cornea, or middle of the cornea itself, and then you'll know the depth, and then that's where you get the signal peak itself, and then you'll know what the hydration level is at that level itself. Yeah.
So you mentioned there's no good way to measure hydration now. So yeah. And you gave us a nice look to the future, but currently when you're evaluating patients for, Fuchs requiring EK, are you using posterior elevation or what? Yeah.
So basically we use posterior elevation and densitometry. We have a paper coming out, just like we're undergoing vision and ophthalmology science, to look at correlations. We're linking that to genotype as well. So I use posterior elevation a lot. The only problem is posterior elevation is that we see many patients with the ECM matrix basically thickening with fibrillar layer. And in that case, I do use densitometry as well. So I use a combination of densitometry and that cell. So you can have patients who have densitometry changes, and they definitely need to have DMEC because they basically will not be able to see because of the scarring. So these are also, thinking about the future, these are also patients who I wouldn't do cell therapy on as well because they've got scarring in Descemet's membrane. So if you don't remove the Descemet's membrane, the patient's going to have issues with scatter if you just basically take the endothelium off. But likewise, you see many other patients, the densitometry is normal, but they have high posterior or negative posterior elevation, so it's basically oblate structure inside the cornea itself. And of course, they have subclinical edema, like the example I showed, and those are ones obviously need DMEC to avoid subclinical edema. So I do rely on that a lot, but I use a combination of densitometry and posterior elevation as well.
Hi, I'm Dr. Sridevi. So I just had one question. So which area of the cornea do you measure? So do you average it out, or which point, and how much of the surface is measured? Yeah, so you're measuring, so that map I basically showed you is measuring about 8 millimeters of the central part of the cornea itself. Right, and it's taken from basically one signal acquisition itself, and it will measure 8 millimeters itself. Currently now, at the moment, on the phase 1 study, we just had basically single shot measurement taken from the center itself. But now we can generate that map from taking multiple shots from the cornea itself. So it will give you an idea about the variation in the hydration in various areas.
Yeah.
Right.
Yeah,
Thank you.
Across the whole surface.
Yeah, so hi, I would just like to ask that would you think that this technology will help us in determining the cause of hydration? Like, like in viral keratitis?
Okay, so that's a very interesting question. Yeah, so it can, because I'll tell you why, because basically the signal you get from the terahertz can actually distinguish between inflammation and lipid changes itself. Yes. Okay, so you get a lot of information from that signal. So the engineers are always telling us, how do you know it's inflammatosamine, from basically glycosamine to glycan change, or is it inflammatory related? And I told them, look, just get the hydration thing sorted out first of all.
Just the
and then
hydration,
we
like
can.
if we monitor the hydration over a period of time in
Yeah.
viral keratitis,
So it will
especially
change,
the stool
absolutely.
ones.
So the hydration, actually the causes of hydration, whether it's inflammatory based or basically if it's a gag based related to say Fuchs, for example, with water, actually is different at a molecular level. It's just that, and you can pick it up on this signal. So I think later on, then what we will do is once we've recruited all the 150 patients, we will segregate them out clinically on the causes of hydration and also basically the chronicity of hydration as well, because that's going to change as well, right? You can imagine, we know that patients, when they have chronic hydration stuff, it becomes a little more fibrous, basically changing the cornea, so the stiffness basically varies, and so we know that from many studies in the past as well. So that will affect the hydration value itself, but you should be able to, you're absolutely correct. Okay, great, thank you very much, thank you.